Okay, I think we'll start the show. Thanks everyone for taking your time and your day today to join us with our June 11th masterclass with Bioflex Laser Therapy. It's a really great honor to have such a world-renowned speakers and scientists and researchers and physicians to talk about photobiomodulation. So what I'm going to first do is do a bit of housekeeping. Many people have been asking about a manual, and unfortunately there's not a manual for this specific event. I know there is a few emails that indicated there would be one that was unfortunately sent out in error. So for this event anyhow, there is no manual available. We have several speakers throughout the day. Our first speaker is Dr. Ashleigh Bhanjan, followed by Ben Ewan from Halifax. Dr. Bhanjan's from Durban, South Africa. Then we'll be having a bit of a break at lunchtime. And we'll also have a bit of an introduction to our equipment at lunch as well. And that will be followed by Dr. Ryan Darcy, a neuroscientist from Simon Fraser in Vancouver, British Columbia. And also involved with a Neuroflex EEG medical device that we're partnering and collaborating with on research, followed by Dr. Randy Santiago, who is Bioflex Clinical Research Director, and he'll be updating everyone on our new clinical trials that we've been doing, not just the one with NeuroCatch. That will be followed by the last speaker, Professor Daniel Johnstone, from Sydney, Australia. So it should be a really great day. I'm looking forward to the day. Sorry, I'm just reading a few things as I'm speaking as well too. So I'm going to ask Dr. Ashleigh Bhanjan, if hopefully he's there, to pull up his webcam and say hello to us.
Good morning, Dr. David, Ashleigh and crew.
How are you?
We're good.
Excellent.
Thank you.
Yeah. So right now it's what time is it over there? About 3 o'clock or so?
Well, it's just about 3 o'clock here. Sunny day in Durban, South Africa. So I know that most of the guys are still waking up on that side, working their first or second cups of coffee to get them going for the day. It is Saturday after all. Indeed.
I did want to introduce Dr. Bhanjan. He's a specialist neurologist currently working in private practice at Life Entebeni Hospital in Durban since 2009. He graduated as a doctor from the University of Witwatersrand, sorry for that, 2002, and completed his postgraduate in neurology in 2008. And he's been working with Bioflex for almost 5 years now. And he has been working on such conditions, neurodegenerative conditions as Parkinson's and Alzheimer's. He's also a member of Pain Society in South Africa, and has also been treating a lot of patients with chronic pain syndromes such as fibromyalgia and neuropathic pain, and especially neuroinflammatory disorders that Dr. Bhanjan will go over today, along with some, I'm sure, some incredible case studies to present. So I do want to welcome Dr. Bhanjan and taking his time today to be with us, and I'll ask you to share your slide.
Can you see this, David?
Yeah, perfect. And you're good to go. Thanks, thanks, Dr. Bhanjan.
Thank you, and thank you once again for this wonderful invitation. Once again, it's a great honor, and in fact, a privilege. Humbles me to be here once again for the Bioflex Masterclass to share and empower our knowledge internationally on this platform. So thank you once again. My talk is going to be based on a concept which is exploding in scientific research, especially in neurology, and that is in neuroinflammation and its clinical application in patients that we see in neurological practice as well as clinical practice, and how we can try to help this clinical diversity, how we can try to modulate this, perhaps, a common co-founder and pathological mechanism in actually many neurological disorders as we're going by. So thank you once again. So let's get started. Hopefully by the end of it, you'll see why I entitled it The Devil Inside. Conflicts of interest. I am a Bioflex certified practitioner for the past almost 5 years, as Dr. Kanashko mentioned. So in this talk, we're going to discuss what is neuroinflammation, definition, clinical spectrum, the link between this concept of neuroinflammation and many neurological disorders. Is there a common link? How we've advanced with photobiomodulation therapy specifically in these conditions. I'll touch on a little bit regarding the research done in this field, specifically with neuroinflammation and neurodegenerative disorders. And I have a few personal case reports to present at the very end. So the talk is a bit extensive, and just talking about neuroinflammation alone could go on for days. So I will try to be brief, but to the point. So let's start off with the concept, inflammation. Inflammation is defined as the part of the body's complex biological response to harmful stimuli, for example, pathogens, irritants, and damaged cells. Now, this doesn't seem like a bad problem or a negative problem to actually have, and that's absolutely true. So inflammation is actually very beneficial for us to actually heal and make ourselves heal from irritants, infections, etc. So we discuss inflammation in the sense of classifying it as acute inflammation as well as chronic inflammation. Acute inflammation is usually inflammation that occurs after an acute injury, an infection, for example, and this doesn't last too long, seconds to minutes to hours. The problem lies in when this inflammation now progresses to the chronic inflammatory state. As you can see in this diagram here, it's not just neurological disease that is related to chronic inflammation. As you can see, there's autoimmune disorders, including cancers, fibromyalgia-like syndromes, even cerebrovascular disease and cardiovascular disease have been implicated related to chronic inflammation. So if we could understand or better understand what chronic inflammation and neuroinflammation actually is, why it occurs, maybe we should start targeting this form of pathological processes to ameliorate clinical disease processes. The core problem is that inflammation is not how often it actually starts, but how often it actually fails to subside. So this non-resolving inflammation I will refer to frequently in my talk is what I'm referring to. So how often it fails to subside. So for this talk specifically, we're going to be focusing on some of the neurological disorders that we see related to chronic inflammation, and we'll go through that a little bit later. But for definitive purposes, we're talking about neuroinflammation. Simply put, inflammatory responses that are centralized within the brain and spinal cord, and these are termed neuroinflammatory in nature. Specific key points that are important with regards to neuroinflammation is that the aspects of neuroinflammation may vary within the context of disease, injury, infection, or stress. And this is usually why we see different phenotypical presentations of patients, for example, who've got Parkinson's disease or cognitive impairment. So the amount of inflammation varies. Point number two, the context, course, and duration of these inflammatory processes are all critical aspects in understanding of these processes and the corresponding physiological, biochemical, and behavioral consequences. So once again, that explains why we see different clinical phenotypes in patients with the same pathological conditions. We do understand that this inflammation is mediated via numerous cytokines, chemokines, reactive oxygen species, and second messenger systems that are produced by the CNS cells themselves, called glia cells. And we'll discuss this in the next few slides. All this taken into context, there are subsequently immunological, physiological, biochemical, as well as psychological consequences of these neuroinflammatory responses. So neuroinflammation has been deemed to be a double-edged sword, and exactly that. We have inflammation on one side, which is favorable, helps us heal from infection, and and on the other aspect, when it's non-resolving, all of a sudden leads to a whole host of chronic neurological illnesses. So this is the concept that we talk about, non-resolving inflammation. So this non-resolving inflammation, however, contributes to the overall medical burden in our society and is now viewed as a new therapeutic frontier. So in my opinion, targeting a concept like neuroinflammation could be really the key in ameliorating many neurological disorders in the future. Let's just talk about the positive effects of neuroinflammation. Yes, we know that neuroinflammation is required for early brain development. We know this because of active microglial cells that are present in the production of cytokines that are there for the neural networks to begin. It's required for normal memory as well as learning processes. The microglia also provides support, synaptic pruning, and immunological activities within the CNS to keep us active. It also is implicated in repopulation of depleted microglial cells from a local progenitor source through interleukin-1 signaling. So definitely neuroinflammation has its role in maintaining overall good health. The problems lie in when it is non-resolving. Once again, primary damage or secondary damage, either through the physical or mechanical damage of the infective process, the injury or the insult itself, or secondary damage related to the vascular occlusion, ischemic changes, or cell death that happens as a consequence of the primary insult. And primarily, there is breakdown of this blood-brain barrier. And the blood-brain barrier is there for a specific reason, is to provide immunosurveillance, but at the same time, keep you healthy. Once there's breakdown, there's obviously an influx of cytokines, blood flow, cerebral swelling, and this results in a negative outcome, or even death. So this high degree of inflammation over both primary and secondary damage can lead to this chronic neuroinflammatory state that we are discussing, and that may never ever resolve. So the summary, this table tabulated very well. On the left-hand side, the positive aspects and negative aspects. On the right-hand side, you can see low transient inflammation is required for immunosurveillance. Neuroinflammatory signaling is required for early development, memory and learning, enhanced neuroplasticity. You'll hear this term very often today. Injury-induced remodeling as well to induce tissue repair and neuroprotection, a concept that's very important in neurological disorders. However, the negative aspects, traumatic brain injuries, high levels of inflammation, even chronic low-grade inflammation will result in neuronal cell death, impaired neuroplasticity, and the conditions that we would be discussing in the next couple of slides. So, is this the link between neurological disorders, phenotypical diversity? Perhaps. Post-mortem changes of the brains of Parkinson's patients reveals activated microglial cells and increased accumulation of inflammatory mediators in the substantia nigra, which we know is the source of the dopaminergic deficiency syndrome in Parkinson's disease. There's also been long-standing pathological observations revealing prominent reactive microgliosis in the affected brain regions of patients, as well as animal models in various neurodegenerative disorders. And I will go into detail regarding the clinical diversity with regards to the neurodegenerative disorders with respect to neuroinflammation. This has led to epidemiological studies then looking for possible beneficial effects targeting inflammation using pharmaceutics like non-steroidal anti-inflammatory drugs in both Parkinson's as well as Alzheimer's dementia. Experimental evidence shows that the suppression of this inflammatory process mitigates neuronal impairment. This is seen both in vitro as well as in vivo models of various neurodegenerative disorders. So how can neuroinflammation present? Well, as you can see here, this is the entire topic of neurology. So during the context of this talk, It's not going to be feasible for me to discuss each and every one of these topics, but I'm going to give you some salient points here to take home regarding how neuroinflammation can impact patients' clinical presentation and how we can perhaps consider therapeutic modulation regarding the photobiomodulation therapy. So specifically, peripheral nervous system inflammation has been linked to many forms of inflammatory type of neuropathies, especially the CIDP group, the Guillain-Barré group, the neuropathic pain syndromes. Fibromyalgia is also fall under this category as well, but more under the central nervous system disorders. As we notice, it is a central sensitization disorder. Specifically, we're going to focus on the neurodegenerative disorders, and neuroinflammatory disorders such as multiple sclerosis. How does it impact on traumatic brain injury, stroke, autism, as well as the affective disorders, including depression. And we'll touch base on a bit of post-COVID syndrome related to our recent pandemic. So the cells in the nervous system that are responsible for mitigating, for resolving this inflammation and key in neuroinflammation are the glial cells, specifically the microglial cells. As you can see on the picture on the right-hand side, the astrocytes and the oligodendrocytes have a neural stem cell precursor. However, the microglial cells do not. And this could be one of the reasons why we start seeing problems with age. So microglial cells are the focal point of any discussion of neuroinflammation. It is the core. It comprises about 10% of the CNS population, both in white and gray matter of the brain and spinal cord. And primary function is for immunosurveillance. So yes, this is a positive function, but things get out of hand when this microglial cells have persistent hyperactivation and causes a whole lot of subsequent chemical reactions that will result in further cell death and neuronal dysfunction. As mentioned, these microglial cells are not replaced from myeloid cells of the bone marrow. So they actually are reliant on interleukin-1, a chemokine, a cytokine, for their production. And this low turnover of microglial cells make them susceptible to the potential pro-inflammatory effects of age, injury, and stress. So the functions of the microglial cells now becomes a bit more complex. I'm not going to take you too much into this, but just simply put, in this diagram, two different subtypes. There's an M1 component, which is pro-inflammatory, and the M2 component, which is more protective, anti-inflammatory. If you just follow down on this curve, on this diagram here, the M1, which is a pro-inflammatory, will result in many other processes, including excitotoxicity, hyperexcitable neurons, mitochondrial dysfunction, release of reactive oxygen species, clinical state, for example, seizures, and further inflammation would result in neurodegeneration if this is non-resolving. On the other hand, M2 component, which is anti-inflammatory, would result in more neuronal repair and development, phagocytosis, more synaptic pruning, and remyelination. So this is more the protective form rather than the destructive form. The astrocytes comprise about 20 to 40% of the CNS population, and they are seen as the brain glue, the most abundant cell type in the central nervous system itself. An important function is maintaining the blood-brain barrier integrity. On the other hand, the oligodendrocytes are responsible for myelin production, and we see this a common target for the autoimmune attack in multiple sclerosis when the patients present with white matter lesions that we would see on MRI scans. So, in essence, the initiation of the inflammatory process is protective until there is amplification of the microglial cells and the innate immune response. When there is a non-resolving inflammation, this is unfortunately when the microglial cells in fact starts to target itself and on ongoing protein production that may cause secondary cell messenger systems to cause more further apoptosis or cell death and subsequently neurodegeneration. So concept of non-resolving inflammation is what we're discussing here. Let's start off with the aging process. So we know that the normal aging process provides one of the key examples of the disruption in the communication and the balance between the brain and the immune system. A common geriatric syndrome called frailty discusses and characterizes by age-associated decline in physiological as well as cognitive reserves across multi-organ systems, resulting in increased vulnerability and for adverse health outcomes. The reasons why, as we get older, we're more prone to viral infections and neurodegenerative disorders. So this chronic non-resolving inflammation is probably one of the key pathological processes here in this frailty symptom, either directly or even indirectly, because we also find chronic non-resolving inflammation happening in multiple pathological conditions such as obesity as well as diabetes. So we understand that with age comes elevated circulating cytokines, pro-inflammatory markers, the so-called inflammo-aging. So as we age on its own, the normal process of neuroinflammation is already starting the process off. Add to this now perhaps a bit of stress, psychological stress, traumatic stress, chronic stresses completely now throws off this balance of neuroinflammation. Individuals exposed to chronic stress we show to persistent cognitive as well as emotional dysregulation that contributes to deterioration of overall mental health as well as quality of life. So we see that stress-induced neuropsychiatric disturbances may involve impaired neuroplasticity, once again mitigated by microglial cell activation, monocyte recruitment, as well as enhanced neuroinflammatory signals. So stress on its own, add to the mix as we're getting older, neuroinflammation is trying to do its positive mechanism, but unfortunately, it'll be pushing towards the wrong direction. What happens in traumatic brain injury? Traumatic brain injury, as you can see, complex pathological processes depending on the mechanism of injury and your ability for neuroplasticity. There is microglial activation happening early on in acute traumatic brain injury. And if this progresses to more than 7 days, it's considered to be chronic. And thereafter, further pathological process will start to develop, including apoptosis, pro-inflammatory cytokine release, gliosis or scarring in the brain, and this will lead to further chronic inflammation and neurodegeneration. A simple concept, but unfortunately not well regulated. The clinical this is the reason why you would see patients, for example, who suffer from even mild traumatic brain injury or concussion and have ongoing concentration problems and mood changes and sleeping difficulties, including headaches after a mild whiplash injury they received or they sustained a couple of years ago. This chronic ongoing inflammation is actually mitigating and probably resulting in all the ongoing chronic symptoms despite the event happening years ago. This is the process, the pathological processes happening. Not only are we getting microglial activation, we also see that there is blood-brain barrier dysfunction, which leads to further cell death, axonal pathology, you get astrogliosis, and a surge of all these cytokine and pro-inflammatory cytokine release. And as you can see, it's not a very simple concept to target one aspect of this, especially in traumatic brain injury. You will see this model not in only traumatic brain injury, but in fact, it's akin to many neurological disorders, including the neurodegenerative disorders. And this is probably one of the reasons why pharmaceutics has not been very successful in targeting or finding neuroprotection in these conditions, because targeting one aspect of these multiple pathological processes probably will not, result in neuroprotection in these patients and disease modification. A short tip on autism. Autism, we know that it's a neurodevelopmental disorder. It's associated with a spectrum of cognitive dysfunction. And we do understand that the pathological mechanism is multifactorial here. This is easily visualized in this diagram here, where once again, we see inflammation and increased levels of pro-inflammatory cytokines here and microglial activation in patients with ASD disorders. There's also a significant component of mitochondrial dysfunction, and this unfortunately works hand in hand, mitochondrial dysfunction with neuroinflammation. So mitochondrial dysfunction, once again, resulting in oxidative stress, as well as perhaps some environmental or genetic abnormalities, where we start seeing patients who present with autism and this spectrum disorders. As you can see, multifactorial, but once again, inflammation, mitochondrial dysfunction, environmental links, perhaps with genetic predisposition, leading to the clinical presentation. The neuroaffective disorders, medical conditions such as chronic inflammatory and immunological abnormalities, including obesity, diabetes, and rheumatoid arthritis, including MS or multiple sclerosis, are risk factors for depression. So there's now a link between inflammation and mood disorders. And this is what newer studies indicate. There's impairment of normal structure and function of microglial cells, either by an intense inflammatory activation or a decline of these cells, especially during the aging process. And once again, leads to an impaired neuroplasticity and neurogenesis. This is a lovely summary of the mood disorders, where you can see a spectrum of mood disorders, from anxiety to anhedonia to depression, and how inflammation is unfortunately in this entire link here related to pro-inflammatory cytokine release, how it mitigates neurogenesis and brain-derived neurotrophic factor, the stem cell release, how you get increased neuronal activation of the anxiety pathways. There's monoamine metabolism or reduced uptake with regards to serotonin specifically, and your glutamate metabolism is affected, resulting in excitotoxicity once again. So you can understand and realize that from mood disorders to traumatic brain injury, it's more or less the same concepts that are involved, just on a different scale perhaps, and in a predisposed patient as to which patient will develop mood disorders together with other complementary neurological symptoms. So the pathological processes happening here are very similar. In multiple sclerosis, we do know that this is usually a relapsing, remitting type of problem, which is autoimmune. So the body is attacking the Schwann cells or the myelin sheaths, and resulting in significant neurological impairment. It all depends on the site of injury, which patients will present with optic nerve dysfunction or coordination difficulties or brainstem involvement, speech involvement. So it's all depending on the type and areas of demyelination which we see. But we do understand that multiple sclerosis as well can be a progressive neurodegenerative disorder in the sense of secondary or primary progressive MS. Similar pathological processes are happening here once again, an immune response that is heightened, attacking the myelin sheath, that results in CNS inflammation, and once this continues, will progress towards neurodegeneration. So if we could target the immune response to prevent the ongoing myelin sheath dysfunction, we could prevent further neurodegeneration. The current immunomodulatory therapy for MS is based on the immune activation of the interferons, so that's already working on the immune and the CNS inflammation. This is not curative, unfortunately. It does reduce the relapse rate and recurrence rate of patients. It doesn't prevent progression, unfortunately. These are typical of the white matter lesions that you would see in a patient who've got multiple sclerosis, typical of demyelinating plaques. And usually we see contrast enhancement with regards to active disease when you undergo an MRI with contrast. So here we're describing a neuroinflammatory condition with very similar pathological processes occurring. So what about COVID-19? There's been many postulations, specifically in the context of post-COVID syndrome. So patients who've got COVID symptoms for beyond 4 weeks, according to the NICE guidelines, have persistent symptoms of ongoing brain fog, chronic pain symptoms, ongoing dyspnea, sleep disturbances, brain fog, and neurocognitive aspects inclusive. Postulated mechanisms, persistent viremia perhaps, and this has been demonstrated with clinical studies, that perhaps there's an ongoing active viral replication of the COVID-19 virus itself in the olfactory mucosa of the nose as well as in the gut? Could there be a relapse or reinfection rate? Inflammation is there once again, together with also mitochondrial dysfunction. Is there an element of deconditioning in these patients, or mental factors such as post-traumatic stress disorder as to why these patients are presenting with ongoing, persistent neurological as well as non-neurological symptoms that seems to be not amenable to basic over-the-counter medication use, and doesn't really sort of get better despite many other current forms of therapy that are available. Specifically in post-COVID syndrome, the link between the brain-gut axis is here, where there is chronic ongoing inflammation happening in the gut, which stimulates the vagus nerve, which has a direct portal of entry into the brain itself. So here we can see how neural inflammation is mitigated by the gut through the vagus nerve. Important in treating these patients, as if we had to do treatments, for example, photobiomodulation over the gut in the patient in post-COVID syndrome, this would also theoretically reduce the amount of inflammation that's now progressing to neuroinflammation in the brain. Let's go into neurodegenerative disorders. So specifically, we'll reclassify the neurodegenerative disorders as Alzheimer's type dementia, Parkinson's disease, motor neuron disease, multiple sclerosis is here as mentioned previously, Huntington's disease, as well as multi-system atrophy. For the purpose of this talk, I'm just going to be focusing on Alzheimer's dementia and Parkinson's disease. So the definition of what we define as a neurodegenerative disorder, a group of disorders which result in gradual loss of neurons in discrete areas of the central nervous system. We still don't know why this happens. We do understand it is a progressive, these are progressive conditions, but we do understand as well that there's a timely and well-controlled inflammatory reaction that is essential for the integrity and proper function of the neurological system that goes haywire. This is the reason why certain patients will develop neurodegenerative disorders as opposed to not. And this is the link all I've been discussing with regards to MS, post-COVID syndrome, traumatic brain injury. You have a focal link here with the microglial cells. And as you can see, depending on the type of protein that is produced, either through genetic modification or environmental sort of triggers, and for example, in Alzheimer's disease, we know that there's beta amyloid production. In Parkinson's disease, we know that this disorder is a disorder of synuclein protein. In amyotrophic lateral sclerosis, motor neuron disease, this is the tau protein that is abnormally produced. MS, we understand that there is oligodendrocyte dysfunction related to autoimmune attack on these Schwann cells. So here you can see that in many neurological conditions, especially the neurodegenerative disorders, seem to have a common link based in inflammation, which is resultant in many different protein productions and hence the different clinical phenotypes. So going back to the root cause, if we had to try to modulate what's happening with these microglial cells and the neuroinflammatory component, perhaps the rest would then fall away with time. Unfortunately, this is what we see with neurodegenerative disorders. It's a complex interaction between multiple pathological processes. So targeting excitotoxicity on its own, or oxidative stress on its own, or mitochondrial dysfunction might not be beneficial. But if we could perhaps target multiple areas of this neural networking dysfunctional pathways, including inflammation, mitochondrial dysfunction, etc., perhaps then we could start seeing modulation of disease processes, or slowing down the processes, or even neuroprotection in these conditions. I can't leave out mitochondrial dysfunction, unfortunately, because it seems to go hand in hand. We do know that the photobiomodulation therapy has a primary chromophore of the mitochondrial subunit. So cytochrome C oxidase is lit up. And as you can see here, many neurological as well as non-neurological disorders are primarily related to mitochondrial dysfunction. So including the neurodegenerative disorders I mentioned before, Parkinson's disease, Alzheimer's type, there's muscular dystrophy, diabetes, epilepsy, cardiomyopathies, etc., etc., etc. So keep this in mind as well, that mitochondrial dysfunction seems to be going hand in hand with neuroinflammation. So why are these conditions progressive? And this is a paper that was published many years ago, 2008. Uncontrolled inflammation seems to be driving these disease process. So if you have a patient who's got a genetic predisposition to develop a cognitive syndrome, add to it perhaps type 2 diabetes or obesity, chronic smoking history, and other forms of peripheral inflammatory components, these patients will be higher at risk of developing ongoing neurodegenerative disorders because of a higher load of neuroinflammation that they are dealing with in the brain. Let's discuss dementia. For those, this is the DSM-5 criteria for clinical diagnosis for dementia, including memory impairment, more of the following, including aphasia, which is a speech and language disturbance, apraxia, which means that patients have the inability to carry out motor activities despite intact motor functions, as well as executive functioning decline. And this is usually seen not in the context of a delirium, so patients have slowly progressive histories, and usually this is enough to diagnose a clinical state of dementia. More effective for perhaps the psychiatrists, but as neurologists, we need further investigations, including we use MRI scans, clinical acumen, as well as SPECT scans, which I'll discuss further. This is the burden of dementia, specifically talking about Alzheimer's type dementia. And as you can see, the statistics are overwhelming, to say the least. Very surprisingly on this slide here, notice that between 2000 and 2019, we see that deaths from heart disease have decreased by 7.3%. However, deaths from Alzheimer's type dementia and related conditions increase 145%. Isn't that interesting? Look at the COVID concept with COVID in the mix right now. Alzheimer's type dementias and related deaths have increased 16% during the pandemic. This is staggering figures, unfortunately. And the slide on the right indicates what's been going on for the last decade or so. There are thousands of studies that have been done trying to mitigate, what we're trying to understand with regards to inflammation in the brain, with regards to dementia, for example, and trying to find disease-modifying sort of, pharmaceutical agents where we can actually try to slow down the progression in these conditions. And as you can see here, we haven't been very successful. This is probably because 50% of the time, this is driven by big pharmaceutical companies. And despite the subsequent failures, they will continue striving to get different proteins, molecules, and interventions, trying to aim at looking at perhaps one aspect of the cause of as you would see in neurodegenerative disorders. And unfortunately, it will continue to fail because they seem to be targeting single molecule, single pathological processes. So it's unfortunate. So when we start looking at patients with dementia, patients that come through to us for clinical assessments, we tend to classify them based on a structural classification. So whether it's cortical or subcortical, the cortical types are commonly Alzheimer's and frontotemporal type of dementia. We do see the subcortical type of dementias, the vascular type of dementias, and MS falls in there, as well as the mixed type where we start seeing patients with Lewy body dementia. This is important because we see this in clinical practice, that some patients don't have clear-cut physical signs, neuroimaging signs to indicate either a certain type of dementia. Sometimes they have a bit of an overlap between a vascular type of dementia and frontotemporal dementia. And this is important when it comes to clinical diagnosis. But as you can see, and what we've discussed in the last few slides, is that the pathological processes are much the same. So the different types of dementia have different areas of the brain, for example, that start to show abnormalities, and we look for this specifically on a CT or an MRI scan. Let's talk about Alzheimer's type of dementia. Usually we see the hippocampus. So within the temporal lobes of the brain, we see abnormalities. We also see problems with regards to frontotemporal dementia in the more frontotemporal lobes, so anteriorly in the brain. And this helps us in our clinical as well as radiological assessments of these patients. We use SPECT scans, single positron emission CT, which really helps us light up which areas of the brain are showing perfusion abnormalities. And this is very, very, very helpful in also guiding therapy. Got some very interesting case studies to show you at the end, where we can see SPECT change abnormalities. For example, in a patient who's got frontotemporal dementia, would show hyperperfusion, for example, in the frontotemporal lobes of the brain, as opposed to an Alzheimer's type dementia, which has shown usually problems more posteriorly. We also use non-invasive EEG monitoring for these patients, electroencephalograms, which you can look at brain activity, and this we can use to adjust our treatment modalities, including depending on the frequency of brain waves that we pick up in patients with these type of conditions. So we do understand that Alzheimer's type dementia is a neurocognitive spectrum. Patients are progressing over time, and it usually begins in the medial temporal lobe, the hippocampus, and over time starts to involve other aspects of the brain, spreading more laterally to the temporal lobes, to the parietal lobes, then to the frontal lobes, and then finally to the occipital lobes. Hence the progression of clinical symptoms from short-term memory loss all the way to hallucinations regarding the olfactory, the auditory cortex of the brain. So our aim is to prevent the ongoing progression. And right now, any type of neuroprotection or disease-modifying agents will try to slow this process down from stage 1 to stage 2 or from mild to moderate to severe. And that's our aim, is try to enhance our understanding of these pathological processes that are happening. Just an illustrative MRI imaging of what we would see typically in patients. I'll just give you a few examples here. For example, in a patient who's got frontotemporal dementia here, this is a coronal flare image where we see a lot of atrophy. So there's more sort of widening of the Sylvian fissures here, with a lot more atrophy and ventricular dilatation in frontotemporal dementia, as opposed to a patient which has got a very small hippocampus on both sides here. As you can see here, this patient has got Alzheimer's type as compared to frontotemporal dementia. So it's used in our clinical acumen and diagnostic workup, but put into context with the patient with clinical diagnosis, mini-mental state examination score, family history, as well as SPECT imaging. This is a SPECT scan, which is showing up perfusion. So comparing Alzheimer's type on the left to frontotemporal type on the right, as I mentioned before, there's perfusion abnormalities related to reduced blood flow and glucose uptake regarding this neuronal dysfunction in patients with dementia. And this image shows atrophy and reduced blood flow in the parietal areas of the brain. So the brighter colors is yellowish, orangish, and the impaired perfusion, as you can see, is more on the purplish aspect. And you can see this impaired perfusion bilaterally here in the parietal lobes. Frontotemporal dementia, frontal images here on MRI, and you can see here once again, you don't see actually any high flow through this area. So this is indicative of hypoperfusion, which suggests ongoing neuronal dysfunction in patients with dementia. Very similar pathological process happening in dementia, but we do understand that there's many different theories. There's a metal-ion theory, and oxidative stress theory, as well as cholinergic stress theory that resulted in medications such as Donacept and Aricept being used for patients with dementia. And as you can see, inflammation is once again in the mix. Right at the very end, once these processes are developing, inflammation is there, non-resolving, results in perhaps beta amyloid plaque deposition, neurofibrillary tangles, and the clinical presentation. So what's the evidence now? Okay, so there's been many studies done over the past, I would say, 10, 12 years now, looking at mice models where they looked at continuous wave, pulse wave therapy in the Alzheimer's type model. And for the past 4 or 5 years, I would say, since 2017, you can see now we're now focusing more on clinical studies in in humans specifically, looking to see whether we can actually find some sort of neuromodulatory effect with photobiomodulation. Interestingly, the study seems to be focusing a lot on pulse wave therapy as opposed to continuous wave. We'll discuss this at a later stage during the presentation. This is a study that was published by Saltmark in 2017 with Mary and Liebert. The studies was used to with patients with mild to moderately severe dementia or possible Alzheimer's type dementia with mini-mental state examination scores. They looked at baseline scores of 10 to 24, whether they would improve or not using photobiomodulation therapy. So they used 10 hertz, you can see low frequency, 810 nanometers of LED devices, combining with transcranial and intranasal devices to treat the DMN or the default motor network that they described. They had 5 patients with mild to moderate severe cognitive impairment who entered into the 12-week study. So not a long period of time, that's only 3 months, with a follow-up, no treatment 4-week period. And they used the MMSE as well as the ADAS cognitive scales for statistical analysis. The process involved, the protocol involved, it was in-clinic use of a transcranial as well as intranasal device, as well as daily at-home use of the intranasal device itself. And after 12 weeks, 3 months' time, they found significant changes with regards to mini-mental state examination scores as well as cognitive assessment scales. Together with this, they found improved function, better sleep. Patients' moods were better. There was less anxiety, and wandering were reported post photobiomodulation. This is phenomenal in the setting of dementia. Remember, we're talking about a neurodegenerative disorder. We're talking about patients that don't usually show improvement over time. Here we're showing improvement with respect to examination scores, mini-mental state scores, as well as cognition scales. And hence the reasons why we do require larger control studies to show on a large scale how this can impact patients with mild to moderate dementia. Important to note, no negative side effects. I always get this question, how do you know what's going on? Were there any side effects? That's usually the first question that anybody would ask, especially family members. Are there any side effects? And this is consistent throughout the trials and all the trials that we have read through and have gone through with regards to photobiomodulation, that we don't seem to be seeing much severe neurocognitive or any further neurological related side effects with these patients. Interesting. So this study, photobiomodulation enhances memory processing in older adults with mild cognitive impairment. Remember, mild cognitive impairment, or MCI, is a precursor for full-blown dementia. So if we could stop the process off at the very beginning, we could try to prevent progression over time. They used a specific modality of imaging here called near-infrared spectroscopy here, where they used 18 patients who met the criteria for MCI, were randomized, randomly assigned to a control as well as experimental group. They used real as well as sham photobiomodulation sessions, and they subjected these patients to visual memory scans as well as this functional near-infrared spectroscopy assessment thereafter. And the results are staggering, that you're seeing in mild cognitive impairment patients, only those who received the photobiomodulation therapy and not those who did not. So the sham group shows significant improvement in both aspects with regards to the visual memory performance, as well as the reduction in the hemodynamic response during the task. So the functional aspect of the near-infrared spectroscopy improved. Amazing. Leading on from that, more recently, June 2021, once again, mild cognitive impairment, 3 case reports here. Here they decided to use a slightly longer duration of photobiomodulation. They had 3 patients, 18 sessions, twice a week, basically for 9 weeks. And they used various different cognitive scales to assess these patients. And not surprisingly, once again, they found that patients improved from baseline. They improved within the normal range after the intervention. They even go on to mention that one patient's verbal memory improved from the 1st percentile to the 67th percentile. So we're seeing some really amazing results with regards to photobiomodulation, even early on in patients who've got mild cognitive impairment. And this is where we are today, because whoever has read these articles, whoever has seen this online, on Facebook, on LinkedIn, this is an image of on BBC, because it's everywhere. Because we're all looking for potential, disease-modifying agents. We're looking for what can we do to help our patients with dementia or Alzheimer's disease or Parkinson's disease, for example. And this has resulted in a big hype and explosion, I would say, over the last 4 or 5 years with photobiomodulation and neurological disorders. Personally, I've seen many patients, I would say almost 100 patients with cognitive impairment over the past 5 years. And every single patient seemed to have improved, obviously different aspects with different patients. I've seen much improvement with certain patients, and those that continued more long-term still have had disease-modifying properties. Parkinson's disease, the other unfortunate neurodegenerative disorder, second most common, different clinical phenotype. We know that these patients usually present with features of tremors and bradykinesia. We describe it as slowing of movement, gait problems, and posture disturbances. Also considered to be a neurodegenerative disorder, but we do understand that there is a dopamine deficiency problem in Parkinson's disease, targeting usually the substantia nigra in the midbrain. And this is what typically patients see. The Parkinson's iceberg, what you see is the tremors, the poor gait, the rigidity, but a whole lot of other non-motor symptoms which seem to even predate clinical diagnosis. Very, very similar to what we described earlier in the clinical spectrum from MCI in Parkinson's, in Alzheimer's type dementia. Here we see patients who have a prodromal Parkinson's disease type of disorder that may exist for up to 10 to even 15 years before being diagnosed with Parkinson's disease. So once again, these are prodromal symptoms. If we pick up the patients early, we could perhaps mitigate or prevent progression. Once you start diagnosing, the patients have already lost almost 30 to 40% of the dopaminergic neurons. It's very difficult theoretically to get back what has been lost, but we could help with some sort of neuromodulation and prevention of further progression in the long term for these patients. What's happening in Parkinson's disease? Looks all too familiar. Perhaps, yes, once again, mitochondrial dysfunction, oxidative stress, immune activation, neuroinflammation, same pathological processes, different protein production, different clinical phenotype. This is published in 2019, one of the first randomized controlled trials in Parkinson's disease. This is published in Brain Stimulation. They looked at patients early stages in Parkinson's on the Hoehn-Yahr scale, so patients with asymmetrical disease, but not really wheelchair bound. They had no other neurological disease apart from Parkinson's disease. Patients required to be able to stand and walk for 10 meters without assistance because they use this as a tool to measure the patient's bradykinesia. And patients had no dyskinesia, so fluctuations of regarding to dopaminergic therapy. The patients were instructed to maintain their usual medications and the activities, so there was no other variable that could have adjusted or resulted in the changes that we had that they had looked for in the patient's clinical profiles. And here they used once again something very similar: twice a week, 18 sessions versus sham sessions. And surprisingly, this form of therapy seemed to be adopted from the previous studies, where we don't really need to treat these patients every single day. We're looking for neuromodulation, slow charging up of these mitochondria so that we can mitigate and modulate all this inflammation that we need to with time. So important, we're talking about clinical protocols, duration and frequency of treatment. As you can see, 8 joules per square centimeter used here. And the study results show that the 10-meter walking test, so basically the gait speed, was found to be significantly improved in the treatment group. The UPDRS scale, which is a Unified Parkinson's Disease Rating Scale, is an international scale that most studies that are monitoring Parkinson's disease actually they use this scale to monitor progress in patients. As you can see here, they didn't find a significant change, but then remember that this is a short period of time that patients are being monitored over. You monitor the patient's UPDRS scale over time, and perhaps you would start seeing that these patients get better or improve over time. So that study led to a more recent study published in 2021 by Ann Liebert. And here they're looking at to assess the effectiveness of photobiomodulation to mitigate the clinical signs of Parkinson's disease in a proof of concept study. They used, once again, the transcranial and remote treatment for these patients, of which they had 12 patients with idiopathic Parkinson's disease. 6 were randomly chosen to begin 12 weeks of transcranial, intranasal, as well as neck and abdominal photobiomodulation. Here, once again, they're targeting the brain-gut axis. The 6 remaining patients were waitlisted for 14 weeks before they had started treatment, and then they had assessed these patients after 12 weeks. Patients were assessed for mobility, fine motor skills, balance, cognition before as well as during and after treatment. And what they had found is that they had found within a short space of time, once again, measures of mobility, cognition, balance, fine motor skill were all significantly improved for the treatment group for up to 1 year. And this is important because with neurodegeneration, you would understand the current concept of thinking would be there's an ongoing neurodegenerative process happening in the brain. Yes, we will get some symptom improvement, but it's not going to be long-lived. It's going to be short-lived, and that's probably the case in most cases. And this is why we need to understand that patients undergoing this form of therapy need to continue this therapy in the long term, not only to mitigate and show evolution of their symptoms, but also more frequent treatments that they receive with time, and thereafter tapered over time, will result in more disease modification than anything else. And this is what I've actually found in clinical practice as well. So some of the concerns about getting light therapy or laser therapy devices to the substantia nigra, which we know are based in the brainstem, quite a far distance from the skull itself, is how could it possibly be that light therapy is able to have a stimulation on the brainstem itself? Understandably so. We do understand from cadaver specimens that, according to the literature, light is able to penetrate into the cortex about to 5 centimeters, but perhaps we don't even need the direct stimulation of the brainstem. We could rely on the indirect stimulation. So by placing a device on the skull, we do understand that the skull has bone marrow in it, and immune and stem cells are present, which could have been lit up together with mitochondria and blood vessels. This could travel to the brain stem itself, either through second messenger systems or through the networks that develop because the brain stem is connected to the rest of the brain, motor cortex, basal ganglia, etc. So there's both direct as well as indirect stimulation here that could be the reason why patients are showing improvement in Parkinson's disease. The all too good neuroprotection. This is what we should be aiming for our patients, especially for the neurodegenerative disorders. I'm sure Dr. Norman Deutsch will be discussing this in more detail. But what are we talking about? We need salvation, protection of the neurons. We don't want further neurodegeneration. If there is neurodegeneration, can we slow it down? We need some sort of process to put a stop sign on this process so that we can preserve ongoing function and try to stimulate other neural networks. So this is the ideal for patients who have, for example, neurodegenerative disorders. If we could stop the underlying process, stop the ongoing inflammation, excitatory neurotoxins, oxidative stress, mitochondrial dysfunction, in total, we could start be seeing a whole different clinical phenotype in neurology. And that's the reason why, even if we start these processes off even early on, we could prevent further cell death. This is unfortunately the same scenario that's happening, and the reasons why it's difficult to get neuroprotection is because there are multiple different pathological processes happening, from blood-brain barrier disruption to cell death to oxidative stress to mitochondrial dysfunction to excitocity, etc., etc., etc. And that's why no approved pharmaceutical agents have been developed to date. Difficult to target one aspect and expect a condition to get better. We need to target this entire cycle. So if we could target this cycle even earlier on, perhaps we'll slow down the process. So let's summarize what we've discussed. I know it's a little bit of a muchness for the morning, but neuroinflammation, I understand, it's a broad concept. It's complex, with a lot of complexities within the complex term of inflammation itself. There's a link between the immune system and the nervous system. On top of that, we're only now beginning to start to understand positive as well as negative aspects of this connection, and why we see a clinical diversity of patients who present with neuroinflammatory disorders despite common pathological mechanisms. So I'm going to go on now to more the clinical aspect and of this talk, the therapy, photobiomodulation therapy, and specifically in neurological conditions. One of the major advances and advantages of this form of therapy is that it is non-invasive, and that is a definite must in long-term management and modulation of the brain and other organs. Not only is it non-invasive, we know that it has minimal side effects, we know that it's safe, we know that it's effective, and we know that it targets the cause of the problems. If we had to look at what form of therapy would actually be ideal. We talked about neuroprotection, right? So neuroprotection, yes, definitely ideal. Which form of therapy would target the multitude of pathological events happening? We talked about mitochondrial dysfunction, cell death, excitotoxicity, etc., 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 neuroplasticity, and neuroinflammation. If you could target all these pathological processes, definitely a win-win situation. Something that is non-invasive, something has no side effects. And that is why I believe that photobiomodulation will be the key in driving further research in neurodegenerative disorders, because of the multitude of pathological processes it's able to target with a single application. For those that are new to photobiomodulation and are on this webinar, we understand that photobiomodulation primary chromophore is the mitochondrial subunit, cytochrome C oxidase, and with producing more energy, it has a potent effect on inflammation. And this is not only systemic inflammation, peripheral inflammation, we're still also talking about neural inflammation. So if it has the key to reduce swelling related to a soccer injury or a hockey injury, yes, with certain change of a few parameters, we're able to induce the same chemical effect in the brain, spinal cord, neurons, as well as over the joints. So having said that, if we are able to modulate neuroinflammation, all of a sudden, all of these conditions that we've discussed in this masterclass thus far could be amenable to biomodulation, photobiomodulation therapy. It makes sense because if there's inflammation linked to neurodegenerative disorders, to autistic disorders, to depression, to post-stroke, even in chronic traumatic brain injury and rehabilitation, yes, this is why we would see that the diversity of clinical brain disorders and how a single form of therapy could be assisting many patients with different disorders. How do we administer transcranial photobiomodulation? Specifically, we use the Bioflex Laser Therapy system. So we have a transcranial approach. There's also an intranasal approach that you've seen described in the studies before. There's an intracranial through invasive devices, as some of the studies have been using implantation of devices now to stimulate certain aspects of the brain and certain nuclei, as well as an intraoral. So all these mechanisms can result in transference of energy into the central nervous system. And this pretty much summarizes the entire talk. If we have a patient who has got Parkinson's disease, for example, we understand that there is inflammation linked, there is cell death of dopaminergic neurons, there's excitotoxicity happening in that patient. In that patient specifically, we know that they perhaps have a genetic predisposition to this condition. So if we could mitigate or reduce the amount of neural inflammation, reduce the amount of cell death, reduce the amount of excitotoxicity, all the peripheral and central drivers of the condition, we would then be able to release more stem cells through angiogenesis. So more blood flow to the brain through nitric oxide release, more stem cell release, more brain-derived neurofactor and BDNF release, and more synapses. They've already shown in mice models that you can have neurogenesis if you have the right chemical equation. If you have the right ingredients for that recipe, you can induce neurogenesis, hence neuroplasticity. So by reducing the offending peripheral and central drivers, making the environment more favorable for a favorable outcome, release more stem cells and more neural networks, all of a sudden, perhaps that's the recipe for neuroprotection. Let's discuss a few case studies. So the first case study I've got is a lady, Mrs. A.N., a 64-year-old lady who's got a long-standing history of Parkinson's disease. For the past 7 years, she's been on multiple dopaminergic therapies, seen multiple doctors, including neurologists in the past. She had declined deep brain stimulation as a surgical option for her for personal reasons. She had gross motor fluctuations on cinematic itself and found to have a dopamine dysregulation syndrome. She has been wheelchair bound for years. She has a doting husband who brings her to the clinic every twice a month at the moment, and she had been coming in for treatments for quite some time now, and the dramatic changes that we had seen with her would mitigate and demonstrate how potent photobiomodulation can be. So this is a patient who has got progressive Parkinson's disease on best optimal medical therapy, has got side effects from the dopaminergic therapy, is wheelchair bound, unable to mobilize. After a first therapy of treatment, a single therapy treatment, she was able to make this video in my rooms. She was able to get out of the wheelchair. That's her husband in the day hiding in the back. She was able to get up, as you can see, quite severe stoop posture, and mobilize for the first time. Husband was absolutely amazed. Just to demonstrate, after a single therapy of treatment, what changes can we see? So this will demonstrate significant acute clinical improvement, mobility, gait, and posture. So with repeated treatments, you would expect further improvements with regards to these modalities, and hopefully a neuroprotective effect with time. Mr. SQ is a male patient, a 68-year-old, traveled all the way from Zimbabwe to come and see us at the clinic. Once again, Parkinson's disease, established for 3 years, also on best medical therapy. I saw him recently. In fact, I saw him last month, and he flew down with his family for an independent assessment, and he was very keen on starting the therapy. His clinical features included that of Parkinson's disease. He had cogwheel rigidity, not too much of tremors. I must say, he had a reduced arm swing, and his gait speed, so we measure walking speed, which is directly proportionate to your bradykinesia or slowing of movement. And obviously, the quicker you walk, the less bradykinesia and better off you are with regards to this condition. So his baseline gait speed was 5.79 seconds. His pain score was 49. He had a visual analog scale of 3.2, and his PDRS scale, the Unified Parkinson's Disease Rating Scale, was 19. He was graded as a grade 1 to 2, 1 to 1.5 on the rating scale. We did treatment for him over the transcranial photobiomodulation treatment, as well as over the lumbar spine. So we also include peripheral treatment. We do a modified cranial placement with gut placements for him. And because he had traveled from Zimbabwe, I couldn't do what I typically do, which is do patients' treatments 2 to 3 times a week for 3 to 4 weeks, depending on severity. We had done his treatments on consecutive days to accommodate him because he was only staying in Durban for 2 weeks or so. And interestingly, we found that after 2 weeks of treatment, daily treatments, his gait speed almost halved. His PDRS scale, in fact, went up slightly, interestingly, and his visual analog scale or pain scores reduced in a short space of time. Once again, just to demonstrate that Parkinson's disease, despite it being a progressive neurodegenerative disorder, by starting treatment literally over 9 days, showed significant improvement with regards to his gait, walking speed, mobility, posture, as well as his bradykinesia. So once again, significant acute clinical improvement over a 2-week period. Mr. DW, a 75-year-old gentleman, Parkinson's disease, once again, more established 12 years ago, and best medical treatment, once again, declined surgical options, but a severe dopamine dysregulation syndrome and severe dyskinesias. He's been a patient of mine for quite some time, since 2019, and multiple modifications to his treatment protocol, from transcranial to spinal to gut placements, were done over time. I want you to listen to his testimonial that he gave us prior to treatment in August 2019.
Hi, my name is Darryl Wett, and I was diagnosed with Parkinson's some 12 years ago while I was still employed. I was referred to a neurologist by my GP, Dr. Trista Williams from Scottsboro, and given available medicines at that time, I currently take 5 Parvilet a day, every 3 hours, as well as Azilect and Pexola. At times I experience very severe dyskinesia and also poor balance control, bouts of rigidity, also known as Parkinson's freeze, and insomnia, among other symptoms. Parkinson's disease has resulted in my losing my independence to a greater or lesser degree, as I'm not able to drive on the open road, and I sometimes battle to practice my woodworking, my woodworking recently to Dr. Bhanjan by my GP, who recommended that I undergo low-level laser treatment. I have, after 12 treatments, experienced improvements in all the areas affected by Parkinson's disease, and I'm finding that I'm even able to practice my hobby without fear of the dangerous equipment I use. My improvement is also visible to family and friends. It is hoped that the medical aid fraternity will soon realize the benefits this treatment offers.
Well, that you can see, try to incorporate 2 little videos at once, but you can appreciate the amount of dyskinesia that the gentleman has despite medication. And unfortunately, this is what we see in clinical practice, is that with time, everything would have its side effects. So the dopamine that you actually require to help the symptoms of Parkinson's disease, the tremors and the slowing of movement, will start to have less efficacy and more side effects with time, which we describe as a dopamine dysregulation syndrome. So we started his treatment back in 2019, and he was skipping and hopping in my rooms a couple of months later. As you can see here, he insisted I take out this video for him. And he continued his treatment. This was in August 2020. You can see as he's walking, there's no shuffling gait. He's swinging his arms well on both sides. There's no problems when he's turning. You can also see that his UPDRS scales also start to drop, showing off once again. And later on, in March 2021, he was able to get back to his woodwork, and he left us in the practice as a gift for our work that we had done with him. As you can see, he went from a UPDRS scale 51 to 16 over a space of almost one and a half years or so. Phenomenal improvements, acutely, subacutely, and we're able to maintain his symptoms over time. So this case illustrates the sustained clinical improvement in mobility, gait, posture, dyskinesias, as well as dexterity, and improvements in the UPDRS scale. And hence why I commented on early on, you might not see changes in the scales if you're monitoring patients over a short space of time. So the fourth case, we're talking about a patient who's hypertensive diabetic, 67 years of age, progressive dementia, seen by an independent neurologist, diagnosed as frontotemporal dementia. I remember this patient clearly had profound expressive fluency of speech difficulties, and had come to see me as a last resort because they'd already been seen to by multiple neurologists who unfortunately could not offer any further hope and put them onto symptomatic medication. We started transcranial photobiomodulation for this patient in 2019 over the brain, cervical spine, modified cranial protocols. We did treatments for her slowly, but frequently, up to twice a week. She had 10 sessions. She had been re-evaluated in 2019, just to illustrate the point of she had frontotemporal atrophy in the sense of degeneration. We see this on the axial images here as excessive whiteness, or the CSF signal is very high in the temporal lobes. So there's widening of the sylvian fissures, and this is appreciated on the coronal images as well. So MRI suggestive of frontotemporal atrophy. SPECT scan of the brain. We mentioned what SPECT scans are. So perfusion, we're looking for perfusion abnormalities. Report 2019, asymmetrically decreased moderate perfusion abnormalities in the left frontal, left parietal, left temporal, left occipital, and right cerebellar hemispheres. So as you can see, there is moderate perfusion abnormalities picked up on the SPECT scan done before treatment. This patient underwent photobiomodulation, as I mentioned, over a few weeks. And the SPECT scan on the bottom, and once again, you'll appreciate the color difference here, because as we mentioned previously, the brighter colors signifies higher perfusion. So the bottom is 2019 before photobiomodulation. You can see dull images here. But once again, the arrows are annotated to increased perfusion in the brain 7 months later. So we actually repeated the SPECT scan 7 months later. She continued maintenance treatment after the initial few weeks, two sessions a month, until she had a subsequent repeat SPECT scan, which reported, on comparison to the previous study, there is globally increased perfusion demonstrated in those areas that were showing reduced perfusion. And this indicates a response to treatment. I remember the day the neuroradiologist calls me up and says, "Ashleigh, what have you done to this patient? I've never seen a perfusion scan that got better with time." And as you can see here, perfusion is signifying improved clinical as well as radiological function in this patient. So not only did the patient radiologically get better, the patient symptoms got better, patient's neurocognitive symptoms improved. She was able to function better on a daily, with regards to activities of daily living for up to a year. We submitted this case as well for publication. The next case is a Mrs. RP, a 73-year-old lady, very similar clinical case presentation of neurocognitive progressive decline over 6 months. She became lost in familiar spaces, could not recognize familiar faces too as well. And she had a mini mental state score of 20 out of 30, which is falling onto the mild cognitive impairment categories. She had an MRI scan which showed hippocampal atrophy, generalized atrophy, together with small visceral ischemic changes that we usually see in patients who've got established hypertension, ischemic heart disease, etc. So this was her MRI scan. The white specks of dots that you do see are what we call as small visceral ischemic changes. To the trained neurologist and neuroradiologist. This is generalized atrophy. We see so many MRI scans, so we trained in looking at these scans objectively to see how severe the atrophy actually is. We then subsequently performed a SPECT scan for this patient in February. Once again, before we started any form of therapy, and the SPECT scan shows perfusion abnormalities in both frontotemporal lobes, but in addition, there was asymmetrical perfusion abnormality in the left basal ganglia, in the left thalamus. So subcortical structures were also involved. You do recall the slide where I mentioned how we can see abnormalities in different aspects of the on the MRI and the SPECT imaging, cortical and subcortical. This patient had a mixed picture, frontotemporal and subcortical changes. And hence the comment. Remember, SPECT scan done February 2022 before starting treatment. It looked like it was an overlap type of presentation with frontotemporal dementia, with possibly a vascular type dementia, or even possibly Alzheimer's type dementia because of the hippocampal atrophy seen on the MRI. So it wasn't really clear cut what form of dementia was evolving in this patient. Nonetheless, we commenced our treatment in February. We did 6 weeks of treatment twice a week with a treatment holiday for 4 weeks, modified cranial placements, and we followed her up in June after 4 months. Surprisingly, or not surprisingly, monumental state scores increased to 27 out of 30, now normal. All of a sudden, she wasn't getting so disorientated at home, even in unfamiliar spaces, more orientation, less short-term memory loss, more improvement with regards to activities of daily living. So we decided to repeat the SPECT scans, looking once again, what's really going on. And as you can see, SPECT scans, February on the bottom, June on the top. Once again, the arrows are annotated to increase perfusion once again. Better visualized on this image. Here, even the basal ganglia, so the subcortical areas really lighting up here as opposed to in this aspect here. You can see here too as well some patchy changes here, which increased vascularity and increased perfusion once again. So once again, improved perfusion in the left superior frontal lobe, left basal ganglia area, and as well as left thalamus. Previously, the other previously detected areas of hypoperfusion remained stable, so there wasn't any progression or regression of the perfusion abnormalities seen on the SPECT scan. So not only did we see some sort of neurological improvement, there was perfusion improvements seen as well. So this case report once again will designate how patients don't usually read textbooks, and they can have an overlapping type of dementia, whether it's Alzheimer's type or frontotemporal dementia with vascular dementia. Nonetheless, the pathological mechanisms are the same. Irrespective, didn't matter to us. We still commenced the same treatment, adjusted a few parameters, and we saw improvements after 4 months once again. Mr. AG, K6, hypertensive type 2 diabetic patient who developed a mild COVID infection in August 2021. He was unvaccinated, and I saw him almost a year later. Current symptoms that he reported: doc, I've been to the GPs, I've been to specialists, I've seen everybody that I know of. They can't help me. I've got ongoing fatigue, brain fog, memory loss. I'm short of breath. I can't function. I can't go to work. I can't drive. My back pain is worse. He presented with meralgia paresthetica. For those that don't know about this condition, it's a condition that causes a lot of neuropathic pain in the thigh, especially the lateral aspect of the thigh. He tried numerous types of medication, including pregabalin, Lyrica, neuropathic pain modulators. He declined to have any further imaging or nerve conduction studies done. When I'd seen him, he had a mini-mental state score of 30, so no overt neurocognitive impairment seen. He had a pain score of 44 at baseline and fatigue scale of 23, slightly fatigued on the fatigue scales. We commenced his treatment at the end of April. Multiple sites, as you can see, lumbar spine, chest, cranial, as well as peripherally modified cranial placements. Twice a week, he completed about 10 treatments, saw him after a month, Pain significantly improved. Neuropathic pain, lower back pain, myalgia, paresthetica, and his neuropathy symptoms have subsequently almost resolved. Fatigue, much better. Now able to get back to work, get into the car, drive on alone. Felt so much more symptom improvement. Typically, we're describing here post-COVID syndrome. Exacerbation of peripheral neuropathy. We do know that patients have exacerbation of pain, especially neuropathic pain, so look out for that, which resolved in a month after we started treatment, despite this patient having symptoms for almost a year prior to presentation. So this shows rapid resolution of symptoms, including pain and fatigue in a patient with post-COVID syndrome. Case 7, a Miss S.A.M., a 45-year-old medical rep who was previously well from Johannesburg, who unfortunately developed quite a severe COVID infection in December 2020, requiring prolonged hospitalization. She was not ventilated. She subsequently developed, after discharge from hospital, a right Bell's palsy, which we confirmed on nerve conduction studies as well with a normal MRI scan. But she had prominent ongoing respiratory symptoms. Her lung function had reduced to 70% function, chronic fatigue, dyspnea at rest, unable to function, unable to work, unable to exercise. Seen a pulmonologist who has done a CT of the chest, which showed fibrotic changes in the lungs. So unfortunately, not a good sign, probably related to COVID pneumonia. So there was ongoing sort of inflammatory fibrotic changes happening in the lung. She subsequently developed other problems related to chronic inflammation. Hello, there we go. Hypertension, impaired glucose tolerance. And to top it all, she was on chronic corticosteroid use or prednisone use. So not only did she gain weight, she developed pre-diabetic state hypertension since 2020 and not improved. Of note, she had no other autoimmune disorders that they could detect on biochemical and lab investigations. And this is a lady who had no pre-existing problems with her lungs diagnosed before. I reviewed her at the end of April. So 4 months later, once again, commenced treatment in early May. But unfortunately, she was from Johannesburg, so she couldn't complete the treatments as advised. So she had to return to a sick daughter, unfortunately, in Johannesburg. So she had 5 treatments over a week, daily treatments over a week period in May. She was found to be significantly fatigued. And the fatigue scales, as you can see, the pain scores are quite highly elevated at 109. In June, after we completed the treatment, yes, there was some improvement. Her pain scores improved somewhat, but she still remained in pain. She went back home, but she could only return back in December. She couldn't return to work, so she stayed at home for a few months until she came back again and had a few more treatments with us. In fact, she only had spent another week with us in December. And as you can see, after the treatments in December, there was a significant improvement in her fatigue. Her pain scores started to reduce. But by May 2022, a couple of months later, we see a significant drop in her pain scores as well as fatigue. So we followed this patient up for 12 months. Unfortunately, she was a complicated case with numerous comorbidities, including lung dysfunction, and she developed CT changes on the chest. Currently, she's back at gym, she's back at work, fatigue is gone, she's back to her usual self, a bit of pain and niggling now and then, but overall, nothing much to complain of. This case just illustrating, once again, post-COVID syndrome and how we were able to modulate in a short space of time, but not completely. But once the patients return, how we can complete the neuroinflammatory sort of modulation process to the process where we got her almost symptom-free and her fatigue and back to some sort of function. So Bell's palsy, in fact, had also improved. There's very, very subtle facial asymmetry that you can see at the moment, despite a delay in treatment. So this is just, clinical case scenarios that you would see with patients who can come for treatment, certain patients can't come for treatment, certain patients are away from the clinic for a few months or so forth, just to illustrate now what we can do to help these patients in the long term. So this is the typical type of feedback that we get. Unfortunately, the patients that do come to us, and maybe we should change their mindsets and stuff and not be their last resorts, unfortunately. We're still trying to change their perception rather of neurologists, clinicians, physicians, general practitioners, and the medical fraternity. At the moment, if we can, in fact, start these patients off earlier on, perhaps we can prevent or mitigate the amount of progression that these patients will have in the long time to come. We can save them, from becoming unemployed and losing their jobs and developing depression and subsequently. So, in summary, healing at the speed of light. So even though after many years of research, we do have identified that there is no single drug available that has been developed to benefit or be neuroprotective or induce neuroplasticity, especially in these neurodegenerative disorders. Advantages of photobiomodulation. In this scenario, we suggest that the photobiomodulation therapy, either directly or indirectly, has an effect on neuroplasticity and possibly neurogenesis. And this is probably the reason why we're seeing patients who've got Parkinson's disease that have staggering improvements acutely and sustained over time if they are on the treatments over time. I describe it as a seesaw effect. There's less neurodegeneration, there's more anti-inflammatory effect, and this sort of offsets the inflammation that we know is driving the condition. So induces more good neuroplasticity. So regardless of the initiating mechanism, photobiomodulation is neuroprotective, can restore function following various brain insults, from mild cognitive impairment to traumatic brain injury. So it's not impossible to think now from a neurologist perspective, how can one form of therapy benefit cognitive patient with cognitive impairment, Alzheimer's dementia, frontotemporal dementia, Parkinson's type disease, post-COVID syndrome, etc., etc., etc. We've gone through the discussion that inflammation is there in almost every single condition in neurology. So it's time to go back to the books. It's time to go back and rethink how we treat our patients, targeting the cause of the problems. And we should, if we have an available form of modality, such as a non-invasive light therapy that could assist with neuromodulation, perhaps we should be starting off with these patients earlier on, safely and effectively. So as we all are, we're all getting older with time, some people more than others, but aging of the general population, together with the ever-lengthening lifespans, dementia, Alzheimer's, and Parkinson's disease, unfortunately, will become a global health problem. As I mentioned in the illustrative slide before, heart disease is coming down, but dementia is soaring. There's a problem. There's a mismatch. We need to focus more on our neurodegenerative disorders and what we can do for our communities and our national and international health systems. And I believe that photobiomodulation therapy, specifically for brain disorders, will become one of the most important medical applications of light therapy in the coming years to come. I call it a no-brainer. The DNLC team, thank you for my collaborators, and as you can see, some familiar faces there in the middle. And thank you to my team for all the dedicated work. And thank you for your attention.
That's wonderful. Thanks for the update and all that information, Ashleigh. Really appreciate that. As you can imagine, there's lots of questions. So before we get into the questions, I just want to preface this by saying that, and you can speak to this as well, Ashleigh, as far as specifics, specific duty cycle, frequency, that kind of thing. Obviously, these are individual patients. Things are determined based on imaging, based on clinical presentation, all these different things. Photobiomodulation therapy is not a one-size-fits-all type of scenario. Well, there are generalities, and I'm sure Ashleigh can speak to that as well. So let's get into a few of the questions. Just see here. There's a question here, Marion, whose husband had a heart transplant 17 years ago and received a medication, Lexicon, or something like that. When he came in normal, but was staggering and dizzy afterwards. It seemed to resolve, but then he was left with what seem to be Parkinson-like symptoms, including shuffling gait, that kind of thing. And her question is, would laser therapy perhaps be of benefit here?
Absolutely, David. I think you've knocked the nail on the head right there. With regards to clinical spectrum of disorders and our application and treatment protocols, yes, it's not a one size fits all, unfortunately. This is why we use neuroimaging, we use SPECT imaging, MRI scans, clinical evaluation. I even use a lot of assessment scales to objectively assess these patients from baseline and as we progressing over time. But as you're mentioning in this case here, we see this happening where we see patients developing Parkinsonism or Parkinson's-like symptoms related to medication, a recent stroke, a change of medication, an infection, or even COVID. We don't know why this happens, but there is perhaps an unmasking of Parkinson's disease or Parkinsonism, if I can call it. So yes, the symptoms are similar. They are features of Parkinson's related neurocognitive dysfunction. So tremors, bradykinesia, slowing of movement, slowing of thought, for example. But it seems to be related to the same pathological process happening. So to answer the question, whether it's going to be beneficial to start treatment, yes or no, earlier, yes, no doubt. If there's a pathological process happening, we see it happening. Even a patient who has going for a coronary angiogram unrelated with the cardiologist, and a few weeks later, all of a sudden, there's a tremor in my arm. Was there a stroke that happened after the angiogram or not? No, but this is the clinical spectrum that we're seeing. So these patients have pre-existing neuroinflammation or a genetic risk or lifestyle modification risk profile, and this is somewhat enhanced or unmasked by a small little trigger, and this is what we see. So yes, if you could get your hands on a device to start treatment, absolutely.
A few questions about cerebral palsy and your experience with treating, and maybe some generalities as how you might treat cerebral palsy.
Cerebral palsy, yes, we do have quite a few pediatric and adult patients with the cerebral palsy. We try to discuss each patient individually with the family. We're not looking for curative reasons, but there's a lot of emphasis on assisting with, for example, spasticity. Even it helps with patients who've got post cerebral palsy or anoxic related seizures. So it helps with mood dysfunction. It helps them with sleep, chronic pain management too as well. Very similar to, akin to, I would say, how we would do it for a post-stroke rehabilitation, but this is more acute. Remember, cerebral palsy, we're probably seeing those patients 8, 10, 12 years down the line, where there's a lot of neuroplasticity is sort of more of burnt out, I would say, where they can't sort of get any more improvement unless you change the environment in which the brain is functioning, and this is what we do. So we do slow, frequent treatments, for example, 1 to 2 sessions a week over 4 to 6 weeks, but we target certain areas like spasticity, we target the brain itself, and we look at objective outcomes with a physiotherapist or even an occupational therapist over time. So no doubt, yes, it will improve your neurocognitive abilities, it will improve neuroplasticity, it will not be negative to a patient no matter how long post injury or diagnosis. So yes, we have quite a few patients with cerebral palsy that get better to a certain extent depending on the amount of treatments that's required and administered at the same time.
So would you be targeting the neck, the transcranial, and or the muscles involved? Or
we do all of the above, David. So it'll be peripheral as well as central protocols where we're targeting both the central mechanisms. Yes, most patients with cerebral palsy would have gliosis related to a stroke that happened or anoxic injury at birth. So we target the central aspects. The peripheral aspects will target the chronic pain related to complex regional pain syndrome and spasticity, as well as our brain stem or cervical spine. So we target the entire neuroaxis, not just targeting the core source of the problem.
Right. There's a question about a rare condition called progressive supranuclear palsy, Richardson syndrome. Just two parts of the question. I'll answer the first part about if there's any research on photobiomodulation in this condition. I haven't seen it, and in general, there's more and more research into neurological disorders, but when it comes down to really specific ones, that kind of thing, we're not there yet. But I don't know, Ashleigh, maybe you can comment if you're familiar with or have seen this type of syndrome at all.
Yeah, progressive supranuclear palsy is what we classified as a Parkinson's plus syndrome. So these patients present with Parkinsonism, where they have distinct gaze abnormalities. So hence the term progressive supranuclear palsy. So they have difficulties, in looking upwards. So they have a lot of dizziness and frequently falling backwards and so forth. But the pathological process happening here in the Parkinson's plus syndromes is the same. It's just that the clinical phenotype is slightly different. Specifically, I didn't treat any patients with this condition, but I think that if we had treat patients with Parkinson's disease, I don't think there'll be any different because the pathological mechanism is the same, despite them presenting slightly differently. David, I hope that answers the question.
Yeah, for sure. So a question about, and I've seen some research on depression. I haven't seen anything on bipolar, but your experience, or have you had any experience with some of these DSM disorders along that line?
Yes, and incidentally, I'm a neurologist, so I'm not a psychiatrist, and I don't obviously specifically see patients who have ADHD or bipolar mood disorder unless it's part of the symptom complex of the problems that we are dealing with. But coincidentally, we see patients who've got other symptoms that we're treating, and they have ADHD or mood disorders, and especially depression, or they can't fall asleep, chronic insomnia. It seems to impart a little bit onto some of those symptoms. Different patients differently. And for example, we'll be treating a patient with post-COVID, or we'll be treating a patient who's got an arthritis in the knee with a neuropathy. And they say, but doc, all of a sudden I realize that I just feel more energetic and I can sleep better at night. And I haven't actually taken my sleeping pills for the last week or so. What's really going on? So it's this holistic effect that we see. I haven't specifically, David, treated a patient purely with depression or bipolar mood disorders using transcranial photobiomodulation specifically. I think I would obviously in the future would want to do that with the psychiatrist on board and stuff as well, and maybe even with definitely looking objectively like how we would see on imaging, because there's a whole spectrum range of changes that we would see on neuroimaging with mood disorders specifically. Yes, but no doubt I would say that there is influence in these symptoms, but specifically I haven't targeted them purely.
Right, and that's what we found as well. And I want to mention, some of the research you showed was using different devices, different locations, intranasal, oral, those kinds of things. A lot of comments about like what's the differences and all the rest of it. End of the day, the concept of getting light to the brain, typically indirectly or remotely, that's kind of the goal. So these are just different methods of doing it. Per se, and that's what Ashleigh was pointing out. When it comes to direct comparisons, efficacy, all the rest of it, you have to understand some of these devices aren't available or they're not medical devices. They were used for experimental purposes. There's lots of things to consider, so it's not something that can be answered easily. A couple things, two conditions, Guillain-Barré syndrome. Any experience with that?
No specific experience with Guillain-Barré, but we usually we've seen quite a few patients with the chronic variant of that. Obviously, Guillain-Barré is an acute presentation where patients get globally weak, and we diagnose this on lumbar puncture and nerve studies. But the chronic variant we call CIDP, chronic inflammatory demyelinating polyneuropathy. I have a patient in mind, an elderly patient who's has got pre-diabetes and has got a severe demyelinating neuropathy, which we obviously pick up on nerve conduction studies, and has been through the mill with regards to medications. And usually they treat these patients with immunomodulation. So methotrexate, azathioprine and cytotoxic drugs and stuff as well. And he absolutely refused that option. And we said, okay, let's do your nerve conductions as a baseline, and we'll see how things go. Yes, we understand that it has a significant effect on peripheral immune modulation. So we targeted the lumbar spine, both the whole spine, cervical, thoracic, and lumbar spine, and peripherally as well. And we, in fact, showed, how can I describe? We actually showed improvements on the nerve conduction studies, where initially there was no sensory nerves that were actually firing on the nerve studies. So with photobiomodulation alone, we showed that there was actually neurogenesis. The nerves fired, and it's remained improved. So he's on a maintenance treatment program right now, where he comes in for about twice a month. He has his full treatment done, whole spine, peripheral. He's had no further regression. He is not on any further immunomodulatory therapy, but shows no regression. There was a time where, I think it was COVID, when COVID first started, and there was no access to our units, and we were shut down for almost about 3 to 4 months, where he couldn't come in for his maintenance treatment, and he relapsed. In fact, so every time he relapsed, we repeated his nerve conduction studies and showed that at that stage, he regressed. His sensory nerves were not firing anymore. He had clinical deterioration. But once we started him back again, yes, he improved. So yes, in CIDP, I've seen a lot of improvement. Neurophysiologically, there's actually sensory nerve fibers that were never present, all of a sudden start firing again. It's always a good sign.
Right. And there's lots of questions about how you're treating. So I'm gonna mention a couple of things here, and then I'd like you to expand, Ashleigh. Firstly, when Ashleigh started to use Bioflex, he was unfamiliar with how to treat. Dr. Randy Santiago, our clinical research director, worked with Ashleigh as far as giving him some foundations and some basics as to settings and what to work with. We do that on a one-to-one basis. So as a starting point, you can reach out to us, and Randy can make some suggestions. I know that Ashleigh will use placements depending on the symptoms, the location, those kinds of things. I want Ashleigh just to expand a little bit on a couple things. One is, when you mention about transcranial or modified transcranial and say neck plate treatment and or peripheral plate treatment, are you doing all those on the same treatment visit? And how would you in general approach, say, using the arrays on transcranially? Do you have standard sort of ones that you always do, or is it just really based on the individual?
Yeah, so David, great question, but a lot of uncertainties in the answers to as well, because as you know, this is also research and development. And yes, Randy has been assisting me with the guideline of how to go about doing this. And we use our clinical knowledge, we use common sense, we use the research that's been put out there. But as you mentioned, certain devices are intranasal, but they transabdominal 8 joules versus 14.6 joules versus an transabdominal placement versus a transcranial placement. So I look at each individual patient, and if it's a neurodegenerative disorder, I always include a gut placement. This is not done on every single visit. So we alternate as a treatment protocol. So we know exactly when to do it, maybe on alternate treatments. We don't do brain, spine, and peripheral treatment all at one go, because we understand, the treatment intervals, the treatment curves, and so forth. We don't want to give too much of light therapy from the physiology of science and science of light therapy itself. So sometimes going slower with not too much of light therapy is more beneficial. So we would do, for example, a transcranial, where we would do, let's just say the patient has got Parkinson's disease. We would start off by focusing on where the brainstem area is, which is the high cervical spine. In that region, not really spine, so higher up, so more between the ear regions, the earlobes, where we're targeting the brainstem. We would also do cranial placements in all aspects, depending on symptoms, gait problems, that we could do the frontal lobes, temporal lobes, whether they have coexistent memory issues. And we would we would do a treatment protocol where we would alternate the placement of these arrays based on the symptoms that we see. As you see in one of the case presentations, the one patient has got spec changes seen in multiple areas: subcortical, cortical, frontotemporal lobes, the occipital lobe, the cerebellum. That's in the entire brain. So we can't obviously do placements in multiple aspects. So we try to tailor it to where we give the effective dose of therapy within the treatment sit down, and we would focus, for example, a gut and a brain placement, or a cervical spine placement, or brainstem placement, and a peripheral placement. And I hope that, you know, this is a rough guideline. We are extrapolating information used and published with using different devices and intranasal devices and so forth. But as David mentioned, it's the concept of delivering the similar type of energy, similar site to get the same outcome. I hope that explains it, David.
Yeah, and I should just also further mention that you know, you can use us as a resource for general questions about treatment. You know, this is off-label experimental use, and I mentioned earlier, Randy Santiago here is our go-to for that. So for all of those who are inquiring about this, you know, Randy can at least sort of give a bit more generalities and sort of some approaches how we've taken it. Ultimately, the how you modify or change the treatment will be based on your patient and how they respond as well. I'm thinking we should wrap it up because we have Dr. Bhanjan waiting anxiously in the hallway here. So Ashleigh, I want to really thank you. Oh, by the way, I should mention that, did you hear about our famous pop singer Justin Bieber coming down with Ramsay-Hunt syndrome? Did you hear about this?
So I heard.
Yeah. So I'm wondering if anyone out there has any connection to the Biebs, and maybe hook them up to Bioflex, because you mentioned Bell's palsy and facial nerve issues. I can say that we've seen really good results with that, and maybe just want to quickly comment, and maybe we can get this out to the Biebs and get free Tim Hortons for life over here.
Yeah, we've treated plenty of patients with Bell's palsy. Ramsay-Hunt is just obviously another variant of that, but it seems to be post-viral, David. And I think that the sooner you contact Mr. Bieber, the happier he's going to be. So most definitely, he needs to be singing, otherwise he's not going to be making any money.
Yeah. So we'll see what happens. But anyway, thanks again, Ashleigh. I really do appreciate the time today that you've taken to share your amazing clinical results.